welcome to our webinar today. It's a real pleasure to have you joining us. Thank you to Nestlé for facilitating this event. Thank you for registering. Thank you for joining us live and for being part of this. So today we're going to look at some complex management of patients, and we've got a great webinar for you today with 3 key talks and a session for questions and answers at the end. This whole webinar is going to take about 1 hour and 15 minutes. You can start submitting questions and comments and your own experiences through the Q&A pattern. We're really happy, we really want you engaged in the session, so please feel free to share your questions. Thanks to those of you who have already actually submitted questions. That was very organized of you, and so we've got a good bunch to get through, but we will try and address as many of those as time allows. So I'm going to introduce my co-speakers just before their presentations as we go, but I'm going to start off by sharing with you the talk that I've prepared for you on the topic of high energy or high requirements. So these are my disclosures to share with you. So I'm going to talk to you about high requirements today, and really I've got 3 key messages for you. So the first key message is that there are some specific groups within which pediatrics have recognized high requirements. And I'm going to share with you what those groups, who those groups are, and also share with you 3 very practical considerations that we need to think about in this situation. The second key message I've got for you is that there may be consequences to us failing to achieve these high requirements. And I want to highlight what those consequences are and highlight the responsibility we have as dietitians. And lastly, my last key point is about nutrition innovation. And I want to share with you a recent study that we were involved in that illustrates nutrition innovation and what we can learn and what we can take away from this more broadly. So let's start with my first key message then. There are key groups that have high requirements. Now, one of the best papers that looked at high requirements in pediatrics was published in 2015. This was Kyle's work from the States. And they described 4 key chronic conditions that are listed here, plus liver disease that I've added, as being associated with high requirements. Now, what's important to remember is that when we're thinking about high requirements, of course, our first thoughts normally go to caloric intake. And yes, all of these conditions are associated with high caloric requirements. But we have to remember that there's a broader aspect to this too, and that many conditions that are associated with high requirements also have considerations with macronutrients too. So protein, for example, is recognized to have a higher requirement in many of these conditions that you see listed here. It's not just macronutrients that can be raised too, obviously there's micronutrients as well. So for example, in cystic fibrosis, we see raised fat-soluble vitamin requirements led to poor absorption of fat-soluble vitamins. Or in short bowel patients, we may see an increased requirement for sodium, for example, if the colon's not intact or we have issues with high outputs. So the main conditions in pediatrics associated with high requirements are generally those chronic diseases. When we think of them, we think of not just caloric, but macro and micronutrient too. But when we're faced with these situations, we need to consider 3 very important factors. The first is that the causes of high requirements can be multifactorial, multidimensional, and individual. So what do I mean by this? Well, it can really cover a broad spectrum. So if we look at some of the reasons why high requirements exist, it may be due to poor intake. And this has led to subsequent deficit in calories or a deficiency in a micronutrient, and this is resulting in a high requirement. This can be related to the disease itself, or it can be related to the medications that are designed to treat that condition. Secondly, we see high requirements where there may be malabsorption or maldigestion. So again, good examples here would be in cystic fibrosis, where there's a lack in 90% of those patients of lipase enzymes, so you get malabsorption of fat, and as a result, you have a higher requirement. Or for example, in short bowel patients, where pieces of the bowel may have been damaged or removed, and therefore the absorption of those nutrients that were to be delivered there simply can't happen or are poorly digested. And then, of course, we look at altered nutrient metabolism that can play a role too. So, for example, increased energy expenditure that we see, for example, in congenital heart defect children, or abnormal body composition that likewise we see in this group too. So lots of different factors may cause an increased requirement in children. What's important to remember as well, though, is that these factors may be weighted differently at different times during the disease course. So, for example, in some cases, it may well be that poor intake is the primary cause of high requirements in a particular time, but then after various forms of treatment, it may be maldigestion or malabsorption that then plays the biggest role in that higher need. Another key consideration in practice is that the time frame for these increased requirements may be different. And these can broadly be separated into three key categories. We've got short-term, medium-term, and long-term. And let me give you an example of different conditions that fit within these. So, for example, short-term. So congenital heart defects, we know these have been associated with high requirements for quite some time. Now, interestingly, though, some work has identified, in fact, this group from Australia, that increase in resting energy expenditure, that higher requirement that we see pre-surgery, actually recovers really quite quickly post-surgery, suggested maybe down as little as 7 days. Now, other work, for example, from Israel has suggested that may not be quite as quick as this, but the principle is that raised requirements in some conditions like this may be very transient and may simply return to normal within weeks. What about medium term? Well, oncology is a good example here. So we have very encouraging data in terms of survival and recovery and outcomes with pediatric cancers in the UK and broadly across Europe too. But treatments obviously go on longer normally than weeks, it's months and sometimes years. So in these cases, it might be more medium term that we see those high requirements. For example, short gut babies, also short gut children will fall into the medium term category where adaptation may start to begin with certain organs that result in improved absorption across different pathways. And this, of course, improves over many months. And then finally, we've got long-term too. So the best example of a long-term high requirements comes in cystic fibrosis, which obviously we've known for a long time has been associated with long-term high requirements, a lifelong higher caloric intake than you would see with a non-CF patient. Now, actually, the landscape in CF is changing quite dramatically. So actually, what we may see in the future is no longer a need necessarily for such long-term high intake or high requirement need, but at the moment, this is very much the category it falls into, long-term. So we have to remember that the time frame for high requirements may vary depending on the condition, but it also might vary within the condition too. And lastly, practically, when we're looking at high requirements, we know we need to be cautious about applying basic equations. So forgetting for a moment higher requirement conditions, we know that the pediatric requirements, the estimated predictive equations we use are not fully accurate. And actually, two very nice studies published in the last few years have identified this quite clearly. And probably the one that most of us know is the Italian study from 2015 that compared nearly 240 hospitalized patients. They took indirect calorimetry, and at the same time they used the WHO, they used the Harris-Benedict, and they used the Schofield equations. And what they found was very poor correlation between the two, to the extent where they didn't really feel that they should be used in hospitalized patients. So I think we do recognize that the accuracy of predictive equations is poor. Universally, that's accepted. Unfortunately, the solution is not universal because obviously most position statements recommend, therefore, the use of indirect calorimetry is the most effective and accurate way of identifying requirements, whether they be high, low, or normal for age. But in reality, of course, we have issues in terms of accessing this as a piece of equipment, the time it takes to undertake it, and obviously the cost and the financial burden of buying such machines. So I think what we're left with knowing that predictive equations may not be or may not be accurate, and actually particularly not accurate in children with high requirements, and not having access to indirect calorimetries, it highlights the need for monitoring so that when we are delivering caloric intakes that we believe to be appropriate for that child, that we're tracking that child's growth plan, make it clear. Now, actually, this is a really nice paper published just in the last couple of months. It's a narrative review looking at the future of sort of nutrition therapy. And really, when you look at it and you read it, it talks about artificial intelligence, but the broad principle is about personalized nutrition. And that's really where things are going. And I think particularly in the cases of high requirements and low requirements, the more personalized we can make it, really, the better. So my first key message was there are some specific groups that I hope I've highlighted for you, and that we need to think practically about this situation in clinical situations. So we need to think that, yes, the causes may be multifactorial and may vary with time. The time frame may vary within condition as well as between conditions. And also the predictive equations that we have available to us, they have limitations and we need to be cautious. Okay, so my second key message for you in relation to this topic is about the consequences of not achieving those high requirements in those children that we see. Now, I work in clinical practice and I appreciate the responsibility that I have and that my colleagues have in terms of assessing nutrition and delivering the correct nutrition to support growth. This is our responsibility as dietitians. And so it's important we recognize the consequences that are there. Now, on a very basic level, I think we all understand that on a single individual level, malnutrition has consequences in terms of the health costs associated with that, and more broadly, the earnings of that individual in later life. And if we multiply this up, of course, across society, what we see is a real worrying picture, both in terms of undernutrition and overnutrition, having consequences in terms of a huge financial burden to us. But let's microscope down a little bit more into the patients that we might see. So hospitalized patients, patients that we see in clinical practice. Many of you will know this very nice multi-center European study in 2015, large number of patients looking at a large age group across the whole of the pediatric life span, actually, 14 centers. And what they identified from this was that there is a relationship between moderate or even severe undernutrition and consequences in terms of length of stay, and also influence on terms of infections and frequency of vomiting and diarrhea. So really important factors that we have to recommend. So there are consequences to not achieving the requirements of any child in hospital. But those consequences become escalated in the context of chronic diseases or those children with higher requirements. So let me give you some examples. So congenital heart defects, say we associate this condition with high requirements. What we've seen in the past is the suggestion that failure to meet those high requirement needs that we see in very early life may have an impact to survival very quickly after surgery. Many months later may have an impact on neurodevelopmental delays. So Ravichankan's work was a very large US study linking those with the poorest linear growth, those poorest achieving their requirements with poorer neuro outcomes. And then even at age 3, those children with the poorest growth in early life still struggling to catch up physically. So congenital heart defects, we see lots of consequences to us not achieving those high requirements. Now, many of these studies are quite little, so I would say that this study here is probably the best that we've got available to us. This was a huge study in 2020, taken across the States, a huge number of patients that was investigated here, most major cardiac centers across the US. And the conclusion that they were able to draw from this huge subset was about the lower the height for AZ score or weight for AZ score, suggestive of malnutrition, suggestive of failure to meet those high requirements, was associated with increased mortality and other adverse outcomes. What about another one of our examples of high requirements? Oncology patients. Now, in 2015, this very nice systematic review highlighted this association between undernutrition and poorer clinical outcomes. That was shown in 6 out of the 9 studies that were included in this systematic review. And since this time, other work has emerged too. So some work from the Netherlands and equally some work from Italy more recently suggesting this relationship. Now, actually, the Italian study illustrated quite powerfully by using Kaplan-Meier plots that you can see here. So this shows you the poorer BMI Z scores being associated with much worse outcomes at 3 months after diagnosis. And then if you look at it at 6 months after diagnosis, the situation is worse still. So failure to achieve those high requirements being related to those outcomes, and actually independently, that weight loss being seen associated with survival and infections too. So major consequences in terms of not achieving what we want to, and actually it's not just growth and it's not just outcomes like that. Quality of life in those patients is also plays a role with us managing their nutrition in early life too, and that was shown in this very nice study as well. And then lastly, cystic fibrosis, an area that I work in a lot. So we've known this for a long time, this condition where there's an association between the better nutritional status relating to the better lung function and actually better outcomes and in fact better survival. And we've also recognized that, when you look after children's nutrition in very early life, this was the Wisconsin study to 3,000 children, this relationship being very clear. Those children where we achieve those high requirements have much better outcomes, even up to 12 years later. And that's obviously going to then benefit them through into adult life too. Just as we saw in oncology, it's not just about the consequence in terms of growth. Quality of life plays a role too. And this very nice systematic review recently highlighting that exact same point. Now, I think it's important also to recognize that when we're talking about high requirements, we're not talking about limitless high requirements. And I think it's important that we recognize there's a balance. So you can over deliver, and this is why it's so important to monitor intake and monitor growth pattern, given that it's hard to predict exactly what the requirement is. And if you look at some of the data in oncology, we're seeing a prevalence of obesity and overweight status post-treatment, where perhaps that over-delivery has continued to occur. And even in cystic fibrosis, we're seeing the same pattern for overweight and obesity, which historically we never would have seen in this condition, now emerging and actually in quite alarming rates too. And in particular, looking at the quality of that weight gain as well that's going in. So we don't want to over-deliver and just create the excess fat mass. We want to make sure that we're getting good quality as well as appropriate quantity growth. So there are consequences to us not achieving the high requirements that we should be doing in this group of children. It's good for us to be aware of that. Now, my final key message for you is about nutrition innovation and how important this is. Now, as I mentioned, I work in clinical practice, and I've worked in nearly all of those conditions that we've talked about at various stages already today. And I've seen the literature, I have a broad understanding of statistics, and I see the position statements, and I understand the consequences. But the reality is I also see the difficulty that we get in clinical practice and sometimes achieving those high requirements or achieving that sustained growth that we want to. And one of the reasons that we struggle so often to achieve those high requirements is GI tolerance, which can play a role in actually a large number of those patients' groups associated with high requirements. And many factors may play a role in terms of nutrition characteristics that may improve GI function or may allow us to effectively and efficiently correct undernutrition or meet need. And you see some of these here, whether it's the type of protein, the type of fat, or fiber, or the content of it. These are all key important factors. So always what we're trying to do is to find solutions that allow us to match a child's clinical situation with the characteristics. I was lucky enough to be part of this trial here. This was a multi-center prospective observational study over a period of 7 days, identifying a group of patients from these 4 different sites across the UK. And what we were investigating was the tolerance and acceptability of a high-energy peptide, ONS, with some of those characteristics that might help to prevent GI intolerance or improve them. Now, what we recruited was around 20 patients. We got data from about 16 of those, and you can see that many of the clinical diagnoses are those patients that we talked about earlier on, children with chronic conditions with high requirements with suboptimal nutritional status. And the results were fairly encouraging. What we saw in terms of acceptability of these kind of products was relatively good. Of course, this is a group of children, and we're asking them whether they like different flavors, so we're always going to see individual preferences. But in terms of compliance, which is really important for us, over half the cohort of patients were able to tolerate the amount that was prescribed by the dietitian. This is quite reassuring. And the GI data that we've got out of this too, suggesting that the children have no significant GI issues, and actually in many cases they actually had some improvements in GI symptoms, which is really encouraging. Now, I think we have to be realistic. This is an example of nutrition innovation, a new product with new characteristics in a new format. But this data, of course, patient group is small, they're heterogeneous, we've got no long-term growth data outcome. But what it represents is more options. And the more options we have, the greater chance we've got of a solution in clinical practice. And that's really what we're striving for. So I would suggest to people if you can be involved in any of these kind of trials, and it's involving pushing us forward and enabling us to have more options to treat these children, that is great. So to recap my key messages for you again, there were some key groups that are associated with high requirements in pediatrics. And I share with you 3 really important practical considerations: that the causes of these may be multifactorial and it may be flexible and change over time. The time frame for those high requirements may vary between conditions, but also within conditions too. And that lastly, that we need to consider the equations, which really may not be that accurate in this group. So monitoring is really very, very important to ensure, even if we can't quantify those requirements with assessment tools. Remembering that the importance of achieving these requirements is escalated in children with chronic conditions, and we have responsibility to ensure we get the nutrition right in this group of patients. And lastly, that nutrition innovation is really important. We want to efficiently and effectively manage and treat and achieve those high requirements in the patients that we see. And we need development and we need progress to allow us to continue to do that. So thanks so much for listening to this, this first session. What I'm going to do now is to hand over to my colleague. So Carolyn is going to discuss with us the issue of tolerance. So Carolyn has been working in adult neurology across all areas of that speciality for nearly a decade. She's also got experience working in oncology and working in the community, so she brings with us a wealth of experience. And she's currently working at the National Hospital for Neurology and Neurosurgery as part of the UCL. And very recently and very relevantly, she's recently completed a secondment in the ICU as well. So Carolyn, it's great that you could be part of this session today. Thanks so much for being involved, and I'll pass over to you to take us forward. Thanks.
Hi, thank you, Chris, and great presentation there. It was really interesting for me because I don't come from a paediatric background, so that was really helpful to see and interesting, especially the tolerance bits as well. So I'm just going to share my screen and find my presentation, hopefully. Okay, there we go. Okay, so what I'm going to talk about today is an overview of the gut symptoms in neurological disease management, GUSTO tool, and the results of a multi-centre pilot study on its acceptability and feasibility when used in healthcare settings. So as Chris said, I'm a specialist neurosciences dietitian. I work in adults. And just to give you a bit of a background of how I got involved in this study. So what happened was I was working, came back from my 3rd maternity leave, I think. I was working, I'll go through what I'm going to talk about. So background to GUSTO, the development process, the GUSTO tool development summary, a survey that was produced in SBEN, and a pilot study that we completed in 2021 that was presented at SBEN, and then some learning points that I've had from doing this whole process. So yeah, just to give you a bit of a background. So yeah, I came back off my 3rd maternity leave. I was working at the time at Regional Hyperacute Unit at Northwick Park Hospital. So that unit is a 23-bedded unit, 22, 23, and it's hyperacute. And we used to have about 17 peg feeds at any time. And a lot of people with tracheostomies, and we'd often have long-term patients that would stay up to 3 months. And what I found when I came back off maternity leave is that suddenly there was a lot of jejunostomy tubes being placed. And I'm all for jejunostomy tubes in the right situation when you've exhausted all opportunities. But when I look back through the notes, I realised that actually, there wasn't a clear process that had been followed all the way through, and you hadn't excluded and changed different things before jejunostomy tube was decided. The decision was made to go in. Obviously, this is for people that were having vomiting issues, or a few patients that are having vomiting issues. So back in 2018, I was chatting to one of the sisters on the ward, and I was saying, wouldn't it be great if there was, some kind of flow sheet that you could use that the doctors could look at as well, and you could, have a sort of troubleshooting, chart to work out, to try different things to see if you can help with the tolerance with the jejunostomy at the end. Now, coincidentally, at that time, my old colleague Tanita, who now works at the Royal Hospital for Neurodisability at Putney, said that Nestle Health Sciences had approached her about doing a project to produce a tool for intolerance in neuro patients. And I couldn't have thought of a better time for it to happen. And it was a brilliant opportunity to get the, to pull something together and also get the experience of other healthcare professionals. And often as dietitians, we don't often have the time to really heavily get involved. So it's great to have someone leading it rather than trying to do it myself. And, what we produced was a lot better than I would have done on my own, for sure. Nicola Graves, who is a dietitian at Nestle Health Science, brought together 4 other healthcare professionals. So there was Dr. Anton Emmanuel. So he's a neurogastroenterologist at where I work now, the National Hospital for Neurology and Neurosurgery. As I said, I was working at Regional Hyperacute, Tanita at Putney, Royal Hospital for Neurodisability, and Emma Carter, who was at the Walton Centre in Liverpool, which is also a neuro centre. So between us, we'd all identified tolerance issues in our areas of work. And again, as I said, no systematic approach to managing issues, jejunal feeding. And what we wanted to produce collectively is a pragmatic guidance for the management of GI symptoms. And what we also wanted, and I think we found, is that often there's not support. And I mean, certainly having worked in the community myself, there's not always that support there. So to have something that healthcare professionals can use with less access to an MDT to the acute. So the development process, this was back in 2018. So we spent a whole day locked in a room in London somewhere. And we had lots of pre-reading papers. Interestingly, a lot of them are pediatric patient papers rather than adult papers. We individually presented case studies. We brainstormed what we felt needed to be included. We went round and round in circles, had a flip chart paper everywhere, Post-its everywhere. Couldn't believe that we'd actually get to something meaningful. And we shared lots of experiences and approaches for next time as well, which was quite interesting with everything that we were sharing. And after a lot of toing and froing, actually in June, it was a very quick turnaround. The Gusto tool went live in 2018. And I say the Gusto tool, it had a long-winded name, and we came up with gut symptoms, and that's where the Gusto came from. So this is the tool. As I can say, I never would have been able to produce that on my own. It's a great tool. We think it's a great tool. I think people have found it quite useful. And Nicola from Nestle Health Science wrote all of the introduction to it, obviously with bits that we put in, but she put it all together. And I have to say, if you're using the adult version of the tool, I would definitely recommend reading that, because it gives you all the really solid information that you need that is part of the tool. And this is the tool itself. Now, again, there will be things that we've missed out. There's things that potentially could be improved on. But from our current experiences in the evidence base, this was the way that we thought it worked best. So what we did is we split it into 7 main symptoms: nausea and vomiting, early satiety, reflux at the upper GI, epigastric pain and abdominal pain and bloating, which kind of fell into both upper GI and lower GI, and then the lower GI, constipation and diarrhea. So all I'm going to do for the purposes of today is I'm going to go through the upper GI. So, and then you can have a look yourselves. So what we split it into was nausea and vomiting, early satiety and reflux, as I mentioned. Now, the first thing we worked through each symptom. So if you had someone that was nausea and vomiting, you'd look at the patient history, you'd initiate a vomit diary if it hadn't already been completed, trying to look at triggers and things that, were causing the vomit. Next thing is definitely rule out constipation by doing abdo x-rays, rectal examinations, and then if constipation present, follow the constipation section. So looking at potential causes for the MGT to consider. For vomiting, you've got to rule out all the systemic infection or sepsis, looking at the vomit diary after it's been filled in for at least a few days, to see if it's linked with hoisting, suctioning, trachecare, and then seek medical advice and continue or discontinue feeding. To be honest, though, what will normally happen, well, if you're on a ward anyway, the medical team will automatically stop the feeding. But if you're in the community, that might not necessarily happen. Ensure feeding tube is in the correct position and the nasojejunal tube or jejunal extensions haven't migrated. That's happened quite a few times to me, and sometimes it's solved a whole issue in some situations, but in cases like this, certainly not. Consider patient posture, any link to medications. If it's the volume of fluid, if you've got a zealous nurse that's popping down about 300 or 400 mils in one go quite fast, that can cause an issue as well, which might take a little time to unpick because you might not realise that's actually happening. And then delayed gastric emptying can also be causing symptoms. So when looking at the upper GI symptoms, looking at potential nutritional considerations. Now, a lot of this was using our clinical experience. We prioritized using the first, second, and third approach to what we would consider to be the dietetic considerations. Now, in our flowchart, it doesn't happen very often, but I think it's because it was 3 dietitians against 1 consultant. We actually managed to get the nutritional considerations before the medical side. However, what we have always said, and I will go on to that, is that we would often run them side by side. So you might change one thing at a time on each one. So the nutritional considerations first line approaches was to reduce the infusion of the rate, change the feed timings, consider bolus versus continuous feeding. You reduce the volume, consider side effects, check the patient's elevated 45 degrees, really basic stuff. But if you've got this to work through, it can really help you go through things. Second line, consider trial of whey-based peptide formula and soy formula for intolerances. And finally, the one that I was trying to avoid, the jejunal feeding. I think what was great about this project is the medical options were, did have a neurogastric consultant, which is quite an unusual kind of person to have as well, because you don't often get someone specialising in both areas. But it was great to have this because we could have solid, medical options to try, and this will be useful for everyone in the, QTAN community to follow, because some people, a lot of doctors, junior doctors aren't experienced in this area. So looking at the antiemetics, if it's just cyclazine or something that's related to movement, a peripheral one like Stematol, consider prokinetics, erythromycin, and then the metoclopramide, but obviously, you might not know, it's avoiding Parkinson's disease and traumatic brain injury because it can cause tardive dyskinesia. But often we would end up using it in the traumatic brain injury patients because the benefits outweigh the risks. And then moving on to the right-hand side, this is more linked with early satiety and reflux, optimize the PPI dose, stop lactulose, there's all sorts of things to consider with that as well. So just to summarize what we felt when we came out of developing the tool was the expertise of Dr. Emmanuel was key in the development and quality of the guidance. As I said, the dietetic versus medical ran side by side. We presented the tool at the Royal Hospital for Neurodisability as part of a study day, the neurosciences group and trauma subgroup of the critical care BDA. And it was introduced as a resource in Electra as part of the PENG clinical update in 2018. It was also, so it is actually digitalized as well, and it's there is also a pediatric version that I haven't been involved in. I was having a look through it. It's very similar, apart from certain intolerance aspects and allergies, I think, as well. So it didn't all end there. It is still continuing. The Gusto Tools survey was developed, a questionnaire developed with Penge and shared with the Penge and NSG for feedback by Sharon Sadora, who's part of Nestle Health Science. And this was a survey to just get feedback of people that had used the tool and what they thought of it. And a poster was produced in SBEN in 2019. Had some great results on there. 65 members took part in the tool. So 68% of people had seen the tool, 38% had used the tool, and 20% had used it on a monthly basis. The area that people most found useful was nausea and vomiting. I guess that's the one that everyone really struggles with, because that is the one that if you can't sort that out, then people are at risk of aspiration and you get your jejunostomy tubes. 98% of people used it in the acute in the community, and 85 to 91 recommended it to other healthcare professionals. And one of the main feedbacks on there that it was user-friendly and practical. So that was a great piece of work, and it was just nice to see that it had been so effective. In the end of 2019 to 2020, Nestle again approached us all again, looking at a service evaluation to ascertain how the tool was working in practice. Now we had an audit of 15 questions that we developed, and we were lucky enough to have dietitian Dr. Dimple Radia, who analysed the audit data in late 2020. I do apologise for my slides. They've come from a keynote rather than a PowerPoint, so they're slightly overlapping. Now, what we did was to have 15 questions, but we just did it as a pilot study within the centres that had already been involved in the research of the original tool. So we had 8 from Putney, 3 from UCLH, so from National Hospital for Neurology, and 5 from the Walton Centre. So what we wanted to get, the information we wanted to get in the pilot study, was things like how many times the tool had been used, what setting it was used in, the MDT members that were using it, diagnosis, length of diagnosis, GI symptoms and length of symptoms, which areas you focused on, did it reflect the problem, outcomes, management approaches that were difficult to apply, time saving, which is quite subjective, and any improvements to the tool. And Dimple collated all the data, and we had some lovely pie charts and bar charts included in that. And I think what was really interesting about the results is that we had dietitians, not only dietitians, but GPs, ward managers, physios using the tool. So it shows how flexible it is across different healthcare professionals. It was mostly used in acute, but also community and rehab. The tool user on average had used it about 4 times, which is great. And the most common patient diagnosis was stroke and traumatic brain injury, unsurprisingly, and most were about 1 to 2 years into their journey. Most people used it for vomiting or diarrhea, or vomiting and diarrhea combined, that dreaded combination that we sometimes get. 25% had 2 symptoms, 50% reported an improvement in their diarrhea and vomiting and discomfort. 88% of respondents said there was a potential saving of nursing time. Now that was really interesting. Again, as I said, it's quite subjective really. But I think what the nurses were saying, it really, you know, once you improve someone's tolerance, you know, less time to clean the patient, less time, you know, personal care, really cuts down on that nursing time, because it all takes a long, long time. 63% said a potential saving of dietetic time by using the tool, and 25% of respondents saying a saving in consultant time as well. And interestingly, 44% have said that family members were much more satisfied. And that, yeah, the nursing quote, as I said, was reducing the time spent changing and, you know, personal care as well. So in conclusion, I mean, basically what we found from our pilot study is the application of the tool in patients with neuroconditions indicating improvement of patient reported symptoms, MDT time. And looking about learning points from this, I mean, what was great was the collaborative working across the disciplines. I wrote an article for Dietetics Today as well, where it was just talking about MDT working across, you know, different areas and different hospitals and how that worked. And I think this is a great example of how things can pull together and really work well. I think what was really nice as well to see with the pilot study that the Gusto tool was used by a variety of healthcare professionals. You know, getting the physios using it is brilliant. I think that will often happen in a rehab setting potentially, because you're working closely with these people, but it just means that you can actually, that other healthcare professionals can use it and it can be really useful. We found it a very supportive tool. I mean, I still use it in practice when I do get an intolerance, although it's not so much these days. Being in surgical and ICU. It doesn't always work in the critical care setting. It's not necessarily appropriate for that. What we've found is that it's mainly neurological, but it can be used across the community as well, not just neurological in long-term conditions. As I say, using different settings. I mean, that's the great part. It can be used in the community as well. And for those GPs or any of the junior doctors that aren't so familiar with this kind of tolerance issue, it can really help them with the medication side of things. And I think most importantly for the patients, it's the quality of life. You know, if you can improve a patient's quality of life, if they're struggling with a tolerance issue, it's just awful watching people struggle. You know, constipation, vomiting, diarrhea, it can be quite upsetting. So if we can improve a patient's quality of life, then that is something that is amazing. So that is the end of my presentation. So I will hand back to Chris, I believe.
That's great, brilliant. Caroline, thanks so much. That was great presentation. And I think it's also so nice to be able to understand the process that these kind of projects go through, you know, and also it's even better when you describe that process starting off, of course, with the post-it notes and then going all the way through to sharing that at a European level and with the quality of work that you get out of it. So really, really great outcome, really interesting. So thanks so much. So moving on to our final talk today. So I'm going to introduce Catherine Simpson. So she's an advanced paediatric dietitian. She works at Central Cheshire Integrated Care Partnership, Mid Cheshire Hospital, NHS Trust. And she's got 20 years of experience covering a really large different areas and different specialities, which is really helpful. She's worked also both in the acute and the community setting, and she's recently getting a little bit more involved in research, and she's published a few really important and interesting clinical case reports as well. So Catherine, is great that you can join us today. Thanks so much again for being part of this. I'm going to control your slides, so just tell me when to move on, and I will do, but I'll pass over to you now.
Thank you, Chris, for that most wonderful introduction there. And it was really interesting to hear both yours and Caroline's talks. So, moving on to my talk. The aim of this session will be looking at the nutritional needs and challenges for children with low energy needs. Low energy needs. What are the clinical indications? Neurological impairment. In the UK, 3 to 4% of children have neurological impairment, with cerebral palsy being a major subgroup of this. Other main clinical indicators are brain injury, genetic diseases, metabolic disease, and neurodegenerative diseases. Neurological impairment. This relates to disorders of the central nervous system, affecting speech, motor skills, vision, memory, muscle actions, and learning abilities. Neurological impairment frequently causes GI problems in children, most notably those with oral, motor function, and motility conditions. These can be very difficult to manage, as you will have heard earlier in Carolyn's talk and the use of the Gusto tool. Such conditions can lead to insufficient calorie intake, gastrointestinal and nutritional complications, which can all have an impact on quality of life for the patient and the carer. So, assessing energy needs in neurological impairment. No specific recommendations existed. ESPGHAN consensus statement provides the most comprehensive overview, medical literature and experts' opinion for neurological impairment. This was formulated in 2017. This is called the Recommendations for Nutritional Management of Children with Neurological Impairments. This consensus statement should be read in conjunction with the ESPGHAN Clinical Advice Guides on dietetic management of children with neurological impairments and common gastrointestinal issues for children with neurological impairments, including evaluation, treatment, and monitoring. So, assessing nutritional status in neurological impairment. The first thing to consider is anthropometrics. These should not just be based on weight and height alone. Weight to height ratios are a poor indicator of fat stores. Skin fold thickness should be used as routine, but this is not without its own problems. Interpretation can be challenging, as fat is often stored around the abdomen rather than skin folds in those with neurological impairment. And more importantly, we also need to consider the child's understanding of the procedure. Often, due to sensory issues, any slightly invasive procedure is extremely scary and often frightening for this group of children. The absolute gold standard for assessing nutritional status is whole body dual energy X-ray absorptiometry. This is the optimal way to assess body composition and truly inform nutritional status. But this is not easy to perform, it's expensive, it's time consuming and requires specialist equipment. I know in hospitals such as where I work myself, we do not have such specialist equipment and nor do many tertiary centres. So, estimating energy requirements. There is no appropriate specific recommendations for assessing the energy needs of children. ESPGHAN's consensus statement recommend the use of dietary reference intakes. They advise that requirements must be assessed individually. Energy needs are influenced by the severity of neurological impairment, the level of physical activity, altered body composition, the state of malnutrition, or the type of paralysis. Overestimation of energy requirements can lead to overfeeding, fat accumulation, and overweight in the long term. Other considerations when calculating requirements in neurological impairment: wheelchair-dependent children often require only 60 to 70% energy compared to a healthy child. Children with spastic quadriplegia have lower energy expenditure than unaffected children. But to counteract this, children with neurological impairment actually require more energy for walking due to increased effort to achieve. Other considerations: total energy expenditure to resting energy expenditure is estimated to be 1.5 to 1.6 for normal activity, but this can be as low as 1.1 in children with cerebral palsy. A note of caution: dietary reference intakes may overestimate energy needs due to severe growth delay and reduced activity. Generally, children with neurological impairment have lower body fat, lower muscle mass, and lower protein stores. and in effect 10 to 15% are actually overweight. So if now we move to look at protein requirements, ESPGHAN 2017 again recommend the use of dietary reference intakes. They consider no adjustment is needed for neurological impairment. Supplementary protein may be needed in specific clinical situations or in children with low calorie requirements. For severely undernourished children, additional protein and energy may actually be required for catch-up growth. So estimating requirements is a starting point only and must be continually assessed. Ongoing assessment and monitoring is fundamental to ensure a patient is meeting their energy and protein needs to avoid both over and underfeeding. Always remember, each child should have a bespoke nutrition plan. So dietary management of children with neurological impairment. Neurological impairment frequently causes GI problems in children. Oral motor function and motility conditions can be extremely complex to manage. The ESPGHAN recommendations around dietary plans. Oral feeding, if nutritionally sufficient, safe, stress-free, and feeding time is not prolonged, should always be persevered. Enteral feeding is to be used if total feeding time exceeds 3 hours. So what type of feed should we use in practice? Before 12 months, the use of human milk, infant formula, or a nutrient-dense formula as clinically indicated. Over 1 year, use a standard 1 cal per mil feed, which is age appropriate with fibre. Consider using high energy density formulas at 1.5 cal per mil for cases of poor tolerance. Low calorie, high fibre feeds for enteral feeding are useful after nutritional rehab in the immobile child. And finally, pureed food should be used cautiously. Consider nutritional adequacy and safety. Although over time this may alter following the British Dietetic Association's latest release of the policy regarding blended diets. So monitoring the ESPGHAN recommendations. Looking at growth and for dietetic follow-up, infants should ideally be seen every 1 to 3 months. Children should be seen at least every 6 months, and older children at least annually, with ideally 6-monthly anthropometry. For severely malnourished infants or children, these may need to be seen more frequently. And a final point to consider is micronutrients. Ideally, these should be checked annually. The paper listed below regarding the assessment and interpretation of vitamins and trace elements in sick children is an excellent position paper to review and read, looking at the gold standards that ESPGHAN also advise regarding around a holistic approach for micronutrient monitoring. I will now move on to tell you a little bit about a clinical case report which I wrote back in September 21. This clinical case report is a patient taken from a study published earlier in the year on the use and tolerance of a high-energy peptide-based pediatric oral nutritional supplement, a UK multi-centre trial, which Chris spoke about earlier. This case report focuses on a female who was 8 years old, known as Miss S. She presented with failure to gain weight in infancy. Neurological impairment, related feeding problems were common, and she also had GI symptoms, which led her to require thickened oral food and fluids, plus a nasogastric tube. She is now PEG-fed and has oral diet as tolerated, which includes 3 meals and some snacks per day. The initial aim was to aim for 75% of energy requirements. This was based on 1,230 calories for corrected weight age and 28 grams protein per day via her PEG. The current PEG plan was 4 times 150 ml of a 1 cal peptide feed with 10 ml water flush, which was providing 600 calories and 15.6 grams protein per day, with oral diet times 3 per day. Early in 2020, Miss S's oral intake declined. This was probably due to a lack of routine. Following COVID-19, there was no school, no respite, and her extended family were unable to support the family the same due to shielding. Food availability was also reduced due to shielding, as the family had to rely on food that other people could bring to them. There was also a concern that this may be the beginning of a decline in her clinical condition. Following the ESPGHAN recommendations, her feed was altered to a energy density formula. The new feeding plan was 4 times 150 ml of a 1.5 kcal per ml peptide feed, followed by a 10 ml water flush. This provided 900 calories and 27 grams protein. In addition, oral diet was offered 3 times per day, and the diet composition included food fortification and texture modification. Following the change in her feed plan, no new gastrointestinal tolerance issues were reported. Miss S's oral intake increased and her nutritional profile improved. The family also commented on improved quality of life. She was able to play again with her toys, and she actually started walking again with the use of her K-walker. Her weight also gradually increased back to the 0.4 centile. So finally, looking at children with neurological impairment, a top 10 tips was written in 2020 for consideration of this client group. These tips were: be aware of the burden of neurological impairment on both the carer and the child. Know how to assess nutritional status. Look at standard anthropometrics and body composition. Know how to identify undernutrition in this client group. Know how to estimate nutritional needs. Think calories, protein, fluid, and micronutrients. Know how to diagnose and treat a gastroesophageal reflux disease. Know how to diagnose and treat constipation. Consider using the Gusto tool, like Carolyn mentioned in her earlier talk. Know when to propose a nutritional plan to these families. And more importantly, be familiar with enteral nutrition. Consider the enteral access routes and possible feeding regimens, which should always be done in conjunction with the families. And know how to choose the best formula. Be aware of the nutrition innovations that are coming through. Consider trying these. Look at what client group they would be most useful to be used. And quite often think outside the box. Do you have children where this could be worth trying? And finally, know the benefits of enteral nutrition, the efficacy, the safety, and will these help to provide quality of life for this client group? I hope that this talk has given you a small overview of the nutritional requirements in children with low energy needs. I would now like to hand back to Chris to summarise our 3 talks today. Thank you for your time.
Great. Well, thank you so much, Catherine. That's wonderful. Great. So we've got everyone back. So yeah, Catherine, thanks so much for sharing all of that great information, particularly all the stuff that's really practical for us as well. So now we've got 15 minutes time for questions and answers. So thank you to those of you who have already been submitting your questions to us. That's great. It's still plenty of time, so feel free now to quickly tap into the box and ask your questions. And whilst you're doing that, we've got plenty to get cracking with. So actually my first question, actually, Catherine, if we can stay with you, the first question that's come in is, how do you meet nutritional requirements in patients with very low energy requirements and prevent undesired weight gain? That's a really practical and really useful question. So are you happy to take that one?
Chris, yes, that's absolutely fine. I think the main thing is really keeping things very, very practical. It's extremely difficult to meet the requirements on different children. I think my main focus would be is look at feed types. As a group of dietitians, we have a massive range of feeds available to us, and it's really looking which fits that box best. It might be in some children that we need to use a high calorie feed and low volume, and others we need a low calorie feed and more volume. And I think it's just looking at all the options that we have available to us and looking at which option best suits that individual child.
Perfect, perfect. That's great. Actually, staying with you just for another one that's coming here about, you mentioned about measuring micronutrients in your talk, which is really useful, and guiding people to the new ESPGHAN position paper. So we're wondering, which nutrients do you commonly identify as low in your group? Which ones do you see as causing causing an issue?
I think from my point of view, the main ones tends to be calcium and iron. They seem to be the two which we struggle with the most. It's very difficult because obviously as each child is very individual, sometimes we don't always do the biochemical monitoring that maybe we should do, and sometimes that's that the families actually don't want that monitoring and say I don't want to put my child through additional blood tests for no reason. So they will be the two which I really tend to find is the biggest problem.
Okay, great, thank you. So right, moving on to another question. This is for you, Carolyn, please. So this one's in adult patients with genetic disorders limit their size and stature. Should we be still aiming to meet adult nutrition requirements for vitamins and minerals? Is the LRNI sufficient?
Yeah, that's a really interesting question, actually, because in adults we have a neuromuscular complex care centre where patients often come in. They have quite low BMIs, although that is the right BMI for them because they have a lot of muscle wasting. So it's really tricky to know whether people are getting the right vitamins and minerals. Like you say, you can work out the weight fine, because if you work through the centile charts and their weight has been stable the whole time, as long as there's no significant weight loss, you can work out the calories and protein. But the minerals and vitamins are very, very difficult to ascertain. Talking to our neuromuscular dietitians, probably, and the best thing to do is to trial the feed. Obviously they're likely to be on a lower volume feed to maintain their weight, and test you can either supplement slightly, and of course the soluble vitamins will just, they're not going to be an issue, but it's more the fat soluble vitamins that are going to be an issue. So really there you want to be checking bloods about once a year. I mean, you could start off on a feed and see if there's any deficiencies, and then start to supplement if there are any deficiencies. But it might be, even though they're not meeting the full, the feed isn't giving them everything as per their age bracket, it might be appropriate for their weight and their condition. I mean, obviously as well, you've got to be careful that some genetic conditions do make people prone to specific deficiencies like percutaneous anemia and things like that. So you just have to really, it'll be on a case-by-case basis. But I think annual blood tests of the fat soluble vitamins and as many vitamins as you can get would definitely resolve that issue.
Perfect. Great, lovely. Thanks very much. That's a great answer. Catherine, back to you now. Along the same kind of line about sufficiency of intake, someone's asked, how can I ensure sufficient protein in patients who have difficulty in tolerating increases in their enteral feeding regimens?
Hey, thank you so much for that. And that one is a very important question. Often when children have very low energy needs, often we aren't quite missing the protein. We could use individual modulars, such as a liquid or a powder one, to make that additional in there. The problem I've often found is where I've added that in there, sometimes compliance is actually low. So sometimes we find that although we advise families to add these modular in, it's just an extra burden on their treatment plan for them to do, and they don't always take on that extra supplement needed. In fairness, what I've tend to find on the flip side of that is some of my pediatric patients, as they move in towards an adult feed, it tends to be double the protein that they need. So sometimes I find my bigger problem is the other end of the spectrum, is that they're moving over to adults that actually are doubling their protein, and that is maybe has a more negative effect than sometimes trying to marry them up when they're younger, really. But my main would be is really have a look at their protein, have a look at our feed options, and then include additional modular protein powders as needed and as clinically indicated.
Perfect, great, thanks. This next one here, this is, says, for clinicians in the community that don't have access to indirect calorimetry, what are the practical ways that we can measure energy requirements for our complex clients? That's a great question. So, I mean, I think the reality is that the availability of indirect telemetry in the community is very limited. The availability of indirect telemetry in clinical practice in hospitals and tertiary settings is also really limited. So it's a relatively small group of dietitians or researchers who've got access to that kind of equipment. So the reality is that we have to go on using predictive equations, and it comes back to the fact we just have to much more closely monitor those children where we're concerned that their requirements might be a way off from what you would expect for age. And obviously that monitoring happens more closely in younger age groups because the rate of growth is faster, therefore you've got to keep a closer eye on it. And as the child gets older and the rate of weight gain slows, obviously then you're going to need a bigger time frame to be able to gauge whether what you're delivering is promoting an excess of weight gain or insufficient weight gain. So I think it's a really important question. We don't have access to indirect telemetry. We have to go with what we've got, and it comes down to monitoring as regularly as you can to make that judgment based on growth pattern. That was a lovely question. So we've got another one here. Carolyn, maybe you'd like to do this one. How would you differentiate between vomiting and rumination?
That's a tricky one, actually. I mean, speaking from a dietetic experience, I think, generally the rumination one is if people are, it's going to be a small amount, it's going to be more like a posset, isn't it? I would imagine. And I'm guessing a lot of carers will be used to a vomit. To me, a vomit is a very large, at least 50 mils, 100 mils of fluid. That would be a vomit to me. Whereas remuneration would just be something maybe that's pulled in the mouth more, so slightly different. Although, either one is not great because, it can lead to aspiration. So I think, yeah, it's a really tricky one. It's a tricky one, that, and not something I've come across. I don't know if any of the other panelists have.
We've certainly seen plenty of children with rumination syndrome, over the years. And I think, one of the things, interestingly, that's been shown to have a really positive impact on that is a diaphragmatic breathing technique, so actually a really non-invasive measure to try and control some of those symptoms. So certainly, yeah, there's been some interesting cases, and if the food is not actually expelled, then you're not losing that from a nutritional point of view. So growth failure, for example, we don't commonly see that in rumination, but obviously there are other consequences of that. Catherine, do you ever see that rumination in your patient groups, or vomiting? Is that a major problem for you, and how do you manage that?
I think one of the major problems I see is usually more it's vomiting is the issue, and it's usually trying to manipulate feeds around. Quite often we do pump-assisted bolus feeds that we just literally try and make these with the feeds. How can we swap things around? We could position. I'll often get our physios involved to see, is there anything we can do from appropriate seating? That can sometimes be an issue, that they might be sitting within a setting but not sitting at the home, because you can only actually get one form of sitting funded. So it's trying to look at not just the feeds, it's looking at the practicalities around how the child is sat, etc. And really, from a medical point of view, I quite often take it back to our pediatricians. Is there anything that they can add further from a medication point of view, or is there any medicine interactions that are helping with causing that problem more?
Right. Actually, staying with you, if we can, there's a question here which is very nice. How do you manage electrolyte requirements in children growing on very, very low energy intakes with poor volume tolerance?
Okay, I think again that's a very, very interesting topic, and I know there's a number of people who actually start using oral rehydration therapy within feeding regimes. We've seen that a few times. Obviously, most of the time electrolyte balance stays quite stable, and from my clinical practice, usually where we've seen electrolyte imbalances is usually when the child is unstable or is actually being admitted to the ward. I've seen it very little as any routine monitoring for patients at home. So I think it's really trying to just look at individual case by case basis. I don't know whether anybody's had different experience of using oral rehydration solutions as part of trying to up them electrolyte balances, because obviously the feeds in children sort of age 1 to 6 just clinically say that they're very low, and those electrolytes I've really yet seen in clinical practice unless they've been clinically unstable.
Carolyn, any experience with this area?
No, not specifically in adults who tend not to have the issues because the feeds are pretty much complete for the more the adult population. So yeah, no, I've not experienced any issues.
Okay. All right, another question actually for you, Carolyn, as well. It's about whether, I mean, your tool looks fairly unique. Are there any other tools that are similar that are used in Europe or the US that you've been aware of, or is this something that's quite specific to the UK at the moment?
Certainly not when we were looking at the evidence base. Whether more things have come out, I think there was something that came out possibly from the BDA. I'm not sure. I think someone mentioned something, but to be honest, you know, after producing the tool, being involved in it, no. But at the time, there was nothing specific when we started in 2018. So not as far as I'm aware.
There you go. Actually, there's another question that might be appropriate for you in terms of tolerance then. So the existence of the acid pocket discovered by Fletcher in 2001 suggests gastric secretions do not mix immediately with food, even in healthy individuals, and will accumulate on the top of the food and stomach after a meal. Do we know if either slow pump feeding or bolus feeding promote greater mixing with gastric enzymes? Is an interesting one.
That is a very, very interesting one. I mean, I personally hadn't heard of this, so I had to look this up today. I'll be totally honest. And it's from it's from 2001, I think, the original study. And interestingly, looking through it, it was for people. So it was on healthy individuals, and they found that there was this gastric pocket that had a really high pH at the top of the stomach and into the esophagus. And then that could actually cause reflux. And the interesting thing is because it's in healthy individuals as well. However, a lot of it was on, so all the work that's been done that I could see, people were given really fatty meals when they were doing this procedure afterwards. So, I mean, we're talking the fatty meals are like fried potatoes, fish, smoked sausage, chicken, pancakes, so really high fat foods, which then might create, you know, a pocket or make things worse. In more recent evidence, in more recent papers, there was some evidence that it might be in gastroesophagus reflux disease, that it's more serious for those kind of people, whereas in the normal population, it's not that much of a problem. So if you've got an issue, then it might make it worse. So PPIs and other antacids can help. In terms of enteral feed or bolus feeding, I think, you know, looking at it, if you were concerned if a patient had reflux and there was something that was troubling you, I think you'd just go down the same route as we did with the intolerance issue. You know, if you bolus someone, regardless of, you know, the fat content is going to be higher, so therefore you could potentially end up with more of an issue. Whereas if you're, you know, for example, in a 2-cal, there's 18 grams of fat. So if that person's having all that fat, if they do have an issue, then, you know, that's quite a lot of fat. Whereas if you have to, you know, a Gevity plus high protein that's going at 20 mils an hour, you're only going to get 2.6 grams of fat per hour. So from that perspective, from a tolerance issue, it could make a difference. But I have to say, looking at all the research, there aren't that many studies on it. And there is nothing, I couldn't find any evidence linked with enteral feed, but that's just stepping it back and looking at it in a logical way, really. But yeah, very interesting. And I spoke to one of our gastroenterology dietitians and one of my colleagues, Tanita from Putney, and we've not heard of it before. So it was a really interesting question and interesting to have a look up as well.
Yeah, that's great. Yeah, brilliant. Thanks. Well, thanks for answering it. And so, okay, so that's great. So it's 8:15 now, so we're going to draw this session to a close then. So thank you to those of you that submitted those questions ahead of time, and thank you to all of you that submitted questions, you know, during this as well. So I would just like to say, I'm sorry, the sound quality was very difficult with Catherine's presentation. So we are going to try and correct that and re-record that so that you will be able to watch that back. So just to say thanks again to Nestlé for facilitating this event. Thanks to all of our speakers for joining and being part of this. There is a button to share feedback for this webinar, and we would really appreciate your feedback. It helps us make webinars that are designed and directed for what the viewers and what us as the clinical practice really need. So please leave us your feedback. Tell us what you think. Tell us what topics you think are useful for us to cover. You're also going to be sent a link as well through the next few days, so you can fill in your feedback then as well. And this webinar is going to be available on this link for a little bit, and then it will be moved to the Nestlé Plus Hub a bit later on. So it will be available on demand. As I say, we're hopefully going to try and sort out the sound for Catherine's lecture so that that'll be a little bit clearer. So thanks again to everybody for taking the time to be part of this session today. I hope everyone stays safe. Thanks so much for joining us, and we look forward to seeing you again very soon.